So we've done the introduction and the agenda. Apologies if it's a little bit slow clicking between them. So in my section's presentation, I'll be explaining what costing, reference cost, PLICS and the national cost collection is. So to start off, we're going to have a quick poll to see what everyone's current understanding of costing is and PLICS. So if you can use your mobile phone and just select which of the 4 options best reflects your current knowledge of costing. Oh. It's a bit quick.
Oh.
Am I able to go back?
I don't think you are.
There we are.
All the other questions do have a warning before that question.
Sorry about that. So costing is the process of quantifying the cost of resources consumed in carrying out an activity. So in terms of the NHS, that's quantifying how much it costs our resources such as doctors and nurses to carry out their activities like wards round, clinics and theatre sessions. PLICS, which stands for Patient Level Information and Costing Systems, takes this one step further to work out how much it costs to treat individual patients. We can build up the total cost of a patient using their data such as their ward stays, their theatre usage, whether they had any test or radiology scans and so on. This gives us the ability to not just say that it costs an average of say £4,000 to repair a hernia, but we can identify the cost of each individual patient that's had that same treatment and use the data to compare why one patient may cost more than another. So why is costing important? Primarily, it's because it helps us to better understand our services. If we don't understand them, then we can't improve them, and it allows us to make informed decisions. We can benchmark against our peers and see what we do efficiently. We can also see what we aren't doing as efficiently as others, and this gives us huge opportunity to learn from others that are still achieving positive outcomes, but spending less than us doing it. We want to use this wealth of information to maximise value for money and make the best possible use of resources, improve patient care and the patient experience. It's also important because this is the information that NHS England Improvement use to set tariff. Our income is therefore based on the results of this data. It can also be used by end users like yourselves as evidence in PDRs, especially if you've used it to make a change to practice. So, next question, what are you hoping to learn from this session? So on the next slide, you'll be given 30 seconds with a free text box to put whatever you're hoping to learn from the session, and you can put a total of 2 responses in. A few more seconds left.
Oh, no, you need to go. Oh. You missed all the responses, Mike.
Am I able to go back or not?
Yeah.
So some good ones there. And hopefully we'll definitely be going through some of those in part of the presentation. And if we've missed anything, we can certainly circle back to some of these. Okay.
I don't think we said at the beginning, but if anybody's got any questions at any point, then you can speak up or type a message in the chat. There will be questions at the end, or just speak up during the presentation.
Okay, so on to reference cost. Reference cost is a mandatory submission that every trust makes annually, detailing what activities we have done and the average cost of doing them. NHS England Improvement use this information to determine what the average cost for those activities is across the country, and they're then provided with a reference cost index, where 100 is the average from all trusts. Anything over 100 indicates that we are spending more on average than other trusts to perform that activity, and therefore inefficiently using our resources. Anything below 100 shows efficiencies. So we brought along 2 examples of 2 different healthcare resource groups, or HRGs, which is the way that the NHS groups treatments, and each one has a distinct income value. So in the first example, we've got the complex hip and knee procedures. In year, we performed 57 of these at a total cost of £604,200. The average cost for the trust to perform this hip and knee procedure is £10,600, and nationally the average cost is £10,452. We are 1% more expensive than the national average, therefore we have a reference cost index score of 101. In the second example, abdominal hernia procedures, in year we performed 22 of these at a total cost of £81,400. The average cost for our trust was £3,700, and the national cost was £4,060. We were 9% cheaper than the national average, therefore we have a reference cost index score of 91. All of these individual reference cost index scores can be combined to give one for a specialty and for the trust as a whole. And as I said before, reference cost, one of its key uses is to determine future year's tariffs, but it's also something that we can use internally as an indicator of where to start looking for areas of improvement. If we are substantially more expensive than the average of our peers, then there may be something that we're doing that's causing that. Conversely, if there's something we're doing substantially cheaper than our peers, then it gives us the opportunity to share our best practice. National cost collection. So where reference cost was the average cost for a cohort of patients at healthcare resource group level, the national cost collection seeks to obtain cost at patient level. It's eventually seeking to replace reference cost as a single national annual cost collection and covers acute, community, mental health and ambulance sectors. You may have previously known this by the name of CTP or the Cost and Transformation Programme, for which it replaced within the last few years. The national cost collection, the big difference is the level of detail that's being collected. The increased granularity of data and auto transparency allows for much more detailed comparison and benchmarking to take place between trusts. It will also allow NHS England Improvement to see more clearly where the costs are within each HRG and to better understand the components that make up that treatment. So as we've said previously, costing is quantifying how much it costs our resources such as doctors and nurses to carry out their activities like ward rounds, clinics and data sessions. Resources are essentially our people, our equipment and our facilities, and we can break them down into two types: patient-facing resources like frontline staff and support resources like us, finance staff. We also have our activities. These are the things that our resources like yourselves, nurses and other frontline staff carry out or do. We know how much our resources cost. We can get that information from our accounts. Costing is the process of identifying how much it costs to perform those activities and then linking these to each individual patient. So now I'm going to hand over to Mike Harrison.
Hi there. I'm going to start off my section with a quick game, just for a bit of fun. Hopefully you're all familiar with the format of Play Your Cards Right. So the first question will just be a multiple choice, and then from there it'll be higher or lower. It's just to gauge how familiar people are with like the rough cost of different things we do as a health service. With Kahoot, you get more points the faster you are, so fingers on buzzers. And if you already know the costs in your trust are different than what I've put here, then I apologise, but these are a mixture of NHS averages and Google search results, so don't for me. Right, so on your phone, everybody, or whatever you're using. So what is the average cost of an outpatient follow-up appointment?
I just did that.
If you try to press it on your screen, on the shared screen, obviously that's what you need to do it on your phone or anything if you're struggling. Anyway, so we've got 5 people got it right there. £133 is the average cost. So from here on out, it's going to be higher or lower. And you might see your name up on the leaderboard if you're doing well. So like I said, outpatient follow-up appointment, £133. So the next one is a cardiac diagnostic test. Is that higher or lower than £133? Yeah, most of you got that right, higher than £133. Some finds there. That's £211 is the average cost of a diagnostic test. Obviously, there's a huge range of cardiac diagnostic tests, so the most common one might not be anywhere near £211. So next up is A&E attendance. Is that higher or lower than £211? That's lower than £211. And Dush taking the lead there. £207 was actually really close, very similar cost, sorry. Next up, an outpatient first appointment, higher or lower than 207?
Lower.
Is lower. New lead there. So an outpatient first appointment is about £161. Next up, a GP appointment, higher or lower than 161?
Oh,
That's lower. Actually quite a lot lower as well, according to Google anyway. About £30 is the average for a GP appointment. Next up, an X-ray, is that higher or lower than £30?
higher.
It's actually lower. An X-ray is like probably the cheapest thing we do in the radiology department. Comes through as £23 is the average apparently. I guess they do a lot of them. A normal delivery birth, higher or lower than £23? Should be an easy one. Higher. Someone's after a cheap delivery there, I think. In the lead now. Normal delivery birth is just under £3,000 on average, £2,840. That includes all the costs for the length of stay. It's for the birth and the length of stay, the whole time that the mother and baby are in hospital. And what about an average of a theatre session? So this is a 4-hour theatre session, higher or lower than £2,840? It's higher. Was at 5 in a row. Neil's at the top. And that's £3,840, which I think it's roughly about £16 per minute. And then ICU bed day, higher or lower than £3,840? It's lower than £3,840. Change at the top. I think that is the last one, which means Neil has won that. An ICU bed day is about £1,270. Yep, so that's the answer. Well done to Neil there. There will be a result at the end, I think, to see the final scores. But we'll move on to the rest of the presentation now. So I'm just going to show you how we can look at some of the outputs of data that we get out of the costing system, and then how we can use that as a starting point for a discussion. So here we have a comparison between the average cost of 2 consultants in the same hospital performing the same procedures. So consultant 1's patients have an average length of stay of 10.4 days, and they're in theatre on average for 370 minutes. They use 1 prosthesis, order 11 drugs, 12 tests and 4 scans on average. And then the average total cost of this procedure is £13,122. We receive £12,500 as income for the tariff for this, which means the trust loses on average £622 per patient. Consultant 1 only performs this procedure 5 times in a year. Now with consultant 2, we see they perform the same procedure but get patients home quicker, only 8.2 days. They spend less time in surgery, 230 minutes. They only use 1 blood product, order 9 drugs, 6 tests and 2 scans. So the cost is therefore significantly lower than consultant 1 at £9,817 per patient. So the trust makes an average profit of £2,683 on each of these, and consultant 2 performs this procedure 50 times per year. So using some external benchmarking data, we might see that the typical length of stay for this type of procedure, and the number of minutes in theatre is somewhere in between the numbers for consultant 1 and 2. And then obviously there might be clinical reasons that require these circumstances, but it may just be that consultant 1 doesn't see this type of patient as often, so they're more cautious than consultant 2 that sees one every week. So these are the costs of the patient that the doctor has control over. So others costing accountants, we're not here to say that you need to reduce this or that. We just try and provide you the information, and we hope that can stimulate conversations between peers. You might wonder why your colleague is doing the same things, achieving the same outcomes, but spending less. And the costing data can help you identify those areas, but we are obviously well aware that it is you and the clinicians that understand the clinical reasons behind these decisions. This sort of data aligns with the GIRF Getting It Right First Time agenda in reducing unwarranted variation. They recommend that specialists doing what they are best at gets the best outcomes at the lowest cost. So looking at a different procedure that consultant 1 does regularly and consultant 2 only does occasionally might show completely opposite numbers, which would just back up the GIRF assertion that there might be a more optimal use of resources. So we've got a quick poll on your phones now. Is having a lower average cost better? So yeah, so it depends.
Depends.
Is the leader there? But if having a low cost isn't always better, then what else should be considered? So you'll have similar to the brainstorm before, you have 10 seconds and you can put in 2 responses. Anything else you should be considering when you're looking at the cost of something? So yeah, we've got some kind of things there: quality, outcomes, patient experience, risk, complication, degree, severity, acuity, length of stay and quality. Yeah, these are all good things. So I think you covered most of the things that I've got here. Logically, obviously, it seems like it would be better for costs to be low, but there are obviously other factors to consider. Were the outcomes for the patient the same, or were there any other issues? Is consultant 2 quicker because they send patients home too early, which might lead to a readmission and an increased cost in the future? Was the surgery too quick, which might lead to a revision? Did the extra test scans that the other consultant ordered catch something or prevent an infection, which might save costs down the line? And obviously these are averages, so maybe one consultant had a single patient that was a big outlier, extra complications which led to a really long length of stay and skewed the data. And then finally, is the data right? Like, was there something wrong in the data accuracy? Was a date recorded incorrectly, or a time in theatre, or something like that? So we can use this data to dig deeper and then try and find the answers. And then once we've fixed any data inaccuracies and ruled out any outliers, etc., then we can begin to look to add value by having discussions on clinical variance, why one consultant might be more efficient than another. So ultimately, costing, it's about value, and value for money isn't always about spending the least amount of money. It's about balancing the cost and the outcomes. We don't just want to save money, we want to save money where money is being spent inefficiently. And obviously, first and foremost, we want what is best for patients. We want to help reduce clinical variation by learning from the cases of best practice. This allows us to achieve the best outcomes whilst offering the best value. So who is involved in costing? The short answer is that everyone is involved. In order to produce costing outputs, we need data inputs from various clinical systems. And to ensure our outputs are accurate, we need accurate inputs to avoid the old saying of rubbish in and rubbish out. For example, it's important that clinical notes are clear and diagnoses are as definitive as possible. All comorbidities should be included. This provides the coding team with the necessary information to identify the diagnosis and procedures that took place. And then all of the clinical data sources flow through to the business intelligence team. They send that data to various external bodies such as NHS and the commissioners. And that's how nationally people know what's going on. And that's how we use the same data to know internally what's going on. And then obviously we get income based on this information. The tariffs are set, the finance team set budgets. And then finally, us in the costing team bring all of those data streams together to determine whether what we are doing provides value. And then we also need you clinicians as the experts and managers of your services to feed back to us. So we don't have the knowledge of your service. We don't always know that something is wrong until somebody tells us that it's wrong. And that feedback loop is essential to getting the costing data right. Engagement between the experts and these other teams is the key to both getting the data accurate and then being able to use it to drive improvements. So we've got a couple of discussion points now. There'll be 2 brainstorms again, same format as before. First one is, how can clinicians help to improve the quality of costing data in their organisations? You'll have 60 seconds on this one. Good, lots of answers. That's good. I think we've got quite a lot of really good things there. Big ones are engaging, getting the data right in the first place, pre-documentation, recording. So yeah, those are lots of good ideas. So I've got a quick summary on the next page. I think again we've covered a lot of them here. So the two main ways that we can improve quality. The first is getting the data right, which a lot of people said. Information being correct from the outset makes a big difference. And then reviewing outputs to see if they make sense on the other end. And then secondly is using your expertise, which a lot of people mentioned through engagement. So how your services are run to provide your costing team with the best data possible. And data might already be right, but there might be other ways you can make it even better by telling them about data that we don't even know exists. We had that in the past. We had an orthopaedic surgeon suggested we use the National Joint Register to get patient level prosthesis data. And that really helped us allocating like a big cost for our trust. We're a specialist orthopaedic trust, so that was a big cost for us to be able to allocate it accurately. And then we've got another one. How can patient level costing information be used to improve patient care? So how can you use the data that you receive from the patient from the costing system to make things better for your service? Yeah, lots of good ideas again. Yeah. Yes, we've got lots of good ideas here. With this one, the options are endless, really. We've got any changes or improvements that you want to make. You can utilise costing data to provide evidence for information. You might want to expand a service, or if you can show it is profitable, then doing more of it can be beneficial. You might want to redesign pathways, moving activities from a theatre to a clinic. The costing data can show you the expected cost based on existing activities. Like I said, we don't have all the answers necessarily, but it can point you in the right direction. I think a lot of these cover those sort of things, like setting up the right clinic and identifying true costs, things like that. Those are really good. So in our experience as a costing team, the best way of improving costing data is through engagement. So we've got a few questions here. The first two are just a quick poll, like we at the very first one. So that'll just pop up straight away. You'll have 10 seconds to answer that one. And then the third one is a word cloud. And for that one, we're just looking for like any data item that you think might be useful to you that isn't just the cost of something. So the first one is, have you met your costing team? So a few of you have, that's good. But this is similar. We've done this sort of presentation before, and it's usually a similar outcome where the majority of people haven't met their costing team. So if you haven't met them, then reach out to them. The national cost collection is mandatory for all acute trusts, so everyone has to produce patient level data. And we know, like personally, we often struggle to get engagement, so or to make clinicians interested. So they'll definitely be happy to have your help and input. If you can approach them with an offer to help improve the data, and they'll be thankful for that. Especially if you can show that you understand that it's a joint responsibility to get the data right. So the next one, is your service profitable? Yeah, it was pre-COVID. Yeah, that's probably true. We've had a lot of changes in the last couple of years, and a lot of you don't know, which is fine. You should be able to assess your profitability in some way. Like I say, speak to your costing team. Ideally, you'll have access to costing data, whether that is monthly, quarterly, or annually. We produced our internal SLR quarterly, and there may even be bespoke reports you can get ad hoc on request from your costing team. You might be unprofitable because the data is incorrect, and it might be that you can help spot an error in the allocation that's gone unnoticed. We aren't experts and we have a huge amount of data. I think somebody's just asked in the chat if there's a costing team for each department division, and there isn't. There's just one for the whole trust. So Mike and I are our costing team, so we cover every single specialty in the trust. So obviously there's a lot of things that we can miss because there's only two of us. So we will notice the big things usually, but anything small we might not see. So that constant feedback loop between us and you that we mentioned earlier is really key to ensuring that the data is good. You can use the data to identify any opportunities to reduce inefficiency, and then there are other tools available as well, such as the model hospital, benchmarking or GERFT. Model hospital data is based on our costing data and suggests opportunities. It's got quite a high profile across trust now, and the trust leadership should be aware of it. So you might be able to use that information to really get some buy-in for any changes you're looking to make. Right, then the next one is a word cloud. So like I said before, any data item you think might help you to make decisions or benchmark against your peers, that sort of thing. Okay, yeah, so in terms of what we can tell you, so there are some of these things that would be included in them, but in terms of like specific metrics, I suppose, that we can use to help you benchmark against your peers, and we've got things like the average length of stay, your theatre usage, including downtime, the number of drugs and tests and scans you order, and we've got all that sort of data available. And that's not an exhaustive list, but I mean, we've got, and basically we have any data that goes into a clinical system, we can usually present it and bring it together with the costs to help you make informed decisions. So obviously, when you say like know the actual cost, we can break it down and we can show you in detail where the costs have been spent. It's all useful information that can help you. But like I said before, it's a starting point. It doesn't necessarily have all the answers. The way we cost things, we might do it at an average cost of something. So when you look into it, it might be that something is looking expensive, and it might be one thing that's really skewing it. So it's about engaging with the data. Right, and that's it for me. I'm going to hand over to Stephen Holt now.
Cheers, Michael. Are you going to do the slides, Michael? Yeah.
You can request control if you want.
Can you do it, because it's a bit
Okay.
finicky before? Yeah. Okay, thank you. So I'm just going to talk about the costing journey at WWL. So our costing journey started in 2009, and since then we've been quite well established at the trust. We've had quite a few costing audits which told us that our processes for engagement were great. However, we knew there was still room for improvement, as we were occasionally getting feedback from clinicians that they didn't understand the data, it was too complicated, what is a trust overhead, and whether the cost should actually be theirs, and so on. Next slide, please. So to improve on this, we knew that the only way to do it, as Michael's talked about, was through engagement. So we set up regular meetings with the clinical teams. So this was so that we could explain the results to them, get feedback on the results, and they could tell us what didn't look right. We engaged with the executive team. We got an executive lead, so we used the costing as a tool for efficiency programs. Also looking at external benchmarking data to identify opportunities. We invested time in training staff on what costing is, how it can be used, and how staff members can access the costing data. One of the best things that we did was we got a clinical costing lead involved. So one of the clinicians became a clinical costing lead. Part of his job plan was to spend a couple of hours every fortnight with the team and to really drive costing forward. And this also helps us to, you know, pinpoint what areas to look at, and also to get the buy-in from his other clinicians. And we constructed new dashboards to display the data. And then what we'd learned through the engagement, we could display that so that we got the buy-in from the staff. Next slide, please. So now I've talked about what we've done in terms of engagement. I've got a few examples of how we've actually used the costing data to make improvements at WWL. So one of the big improvements that we made was in trauma and orthopedics. So we're a specialist orthopedic centre, and through using our costing data and meeting with the clinical team, we identified that complex revision surgery was making a loss of over £2 million each year. So the first thing we did was we met with a clinical lead, checked the data because we wanted to make sure it was right. He signed it all off that it was right. And then we looked at the cost of the complex revisions v primary procedures, and we actually made a profit on those. So then what we did is we looked at it in terms of the girth agenda. So as part of the girth agenda, they want specialist trusts like ourselves to undertake the complex work, whereas it would have been, you know, an easy option to say, oh, we're not taking these from out of area anymore, we're just going to do our own because they're loss making. The girth agenda doesn't actually want trusts who only do, say, a couple of them a year to be doing them. They'd rather them be done at a specialist centre. So what we did was we got in touch with other orthopaedic trusts, and they had the same issues with the tariff, that it just wasn't covering the cost. And then we lobbied to NHS England and the pricing to increase the complex orthopaedic tariff. Okay, next slide, please. So another way that we use costing is one of our partnerships with Liverpool Women. So we've got an assisted conception service at the trust, and then we looked at expanding that with Liverpool Women's. So we use costing first of all to validate the costs for the SLA, and then to also work out the profit share. We used it to develop the business case, and in the end, costing's used each quarter now to agree the profit share with Liverpool Women's. It resulted in a business case that got signed off for Fancy facility at Wrightington, and numerous great service for the people of Wigan, the local population. Now, we've also used costing as part of our efficiency programme. So as previously mentioned, we gave our executive team an efficiency programme, and as part of that, we sense checked our data and then worked with the operational team to try and realise opportunities across the trust. So what we did was we targeted the highest deficit making services and those with the highest national cost collection index score. Essentially, costing was a method of highlighting opportunities for involvement, analysing and modelling the improvement, and the impact of the change. So some of the results that we had, we were able to save 440k by standardising the prosthesis in trauma and orthopaedics. We also changed nurse-led from consultant-led injections to nurse-led, which saved money, and we also changed inefficient skill mixes within therapies. Another way that we've used costing is, before we were on the block contract, the CCG wanted to reduce our community paediatric service block contract. So we used costing to work up exactly how much all the activities were costing. So we got the number of clinics, the MDTs, advice and guidance, and then we've worked up how much it was actually costing compared to what the CCG was giving us, and we actually proved that it was costing us more than the funding we received, so we fully negated the challenge that year. Next slide, please. Okay, so that just shows how we've used costing so far at the trust and some of the big wins that we've had. But I think our vision for costing is that we'd like to see it used in the locality and then understand, the costs of patients going through the system. So from the GPs to the trust to mental health, understand where we could make improvements. So if you've got patients who are frequent flyers and turning up at A&E, but they've also got, mental health issues, seeing the GP quite a lot, is there anything that we could put in place, that would reduce the admissions to the hospital, or maybe redirect the funding to the correct place to prevent admissions? And also this would hopefully have better patient outcomes and help us to reallocate the costs appropriately. So that's our vision. We're not quite there yet, because as you can understand, it's really complex costing. We've got so much data, coming in, and the costs on the ledger, but it's something that we'd like to, get to in the future. So that's a whistle-stop tour of what we've used costing for at WWL. Is there any questions on anything that, I think, how long have we got left? Is it about 10 minutes? Is there any questions on anything that any of us have covered? Either put it in the chat or speak up, or...
Can you just actually explain episodes and spells and how we can sort them out in regard to having episodes within spells? Is that the costing team that needs to sort that?
That comes through the way things are administrated through the PAS system. Usually, I think it's the would it be the data
coding team? Yeah, it's the coding team who work that out. So yeah, each time. So when a patient is within the hospital, they'll have a number of different episodes. So they could come in, go to one specialty, have something, and then transferred. And what they'll do is they'll look at each episode, and then that'll group up into the dominant episode and be coded as a spell under the, given a health resource group, so a HRG. Does that make sense?
So the dominant will always get the full tariff?
Yeah, so it's the dominant spell is what drives the tariff. Yeah.
So if you had a stroke patient who was on the neuro rehab for 6 months, but then orthopedics swing in and fix their hip, because that's an expensive thing, all the money goes to orthopedics as opposed to neuro. Is that right?
So we don't have neuro rehab anymore, but when we did it, neuro rehab was paid on a bed day.
Okay, it's a bad example. I'm just trying to think of something that someone's malingering on a medical ward and then they break their leg. Ortho do the thingy. Does all the tariff go to ortho because they're the dominant? They do the expensive thing, and the poor medics get nothing, or how does that?
There's two different things going on there. There's the tariff is paid as a spell one-off, so the tariff will select the highest value. The dominant thing will select how much money that we get as a trust. But then where it's coded on the ledger is an internal decision, really. And I think for us, we generally code it to the admitted consultant. So it goes to the first consultant that they see. But then in
that case, the orthopedics wouldn't get anything for their hip operation.
So in SLR, that's what we then allocated to the episode. That we weight it by the episode. So the orthopedics would get some of it then. They'd probably get half of it. Or we'd weight it.
So that tariff is then split by you guys in proportionately.
Yeah, so it might not do that in your ledger, but your SLR team might do that. Your costing team might do that in SLR. So we do it by the HRG. So we then split it out to the individual episodes, because we cost at episode level, but we get paid at spell level. So we do the individual costs, and then we allocate the income to those two episodes based on the proportional tariff value of those two HRGs.
Yeah,
so we try and target it to the right place, basically.
Yeah, and that's in a normal year when we're under PBR, but because of COVID, the last year and going forward, we're on block allocation, so it's been really difficult to allocate, the income, because we're not paid on an activity basis at the moment.
And ultimately, it doesn't actually matter, does it? It's still just a pot of money that sits within the trust, to be fair.
Yeah, definitely. Yeah. But yeah, it does help though when you're in PBI, if you can allocate the income correctly and the cost, then you can see, where the areas are to focus on, where like we did with orthopedics, where the income wasn't covering the cost. You can look at, are we doing something different to other trusts, or is it an issue in the tariff, and then approach NHS England then. Is that okay? Alice, have we got your hand up?
Yeah, it's a sort of follow-on question, I suppose, because I come from the labs. So would sort of the labs just get paid per test, or by the, is there a sort of trickle-down effect, or is it just that the lab has its budget within the trust and it all goes according to that?
In terms of costing, the lab is a support service, so it's an indirect cost to patients. So the lab costs get allocated to the clinical specialties that have used it. So each individual patient, they'll get all the costs from their theatres, all the costs from all of the radiology and the pathology, and those things all get grouped up. So pathology on its own doesn't have a patient as such. So it get income or costs. They get allocated out.
Okay.
On the ledger, that's different. Again, that's an internal decision. I don't know how income is allocated to the labs on the ledger. That can be different with different trusts.
All right, okay. And a follow on sort of another question. So infection prevention and control, which is obviously almost outside of all of this, because you don't want it to happen, but it happens. So where do those costs end up?
So we allocate them with so NHS give every trust guidance on how to allocate certain costs, and infection control is I can't remember what it is off the top of my head. I presume it's to all patients get a portion of costs from the infection control team.
Right. Okay.
So every individual cost in the trust, so our costs get allocated to every single patient, and they go via certain methods. So for finance, we allocate our costs out to all of the other specialties based on their budgets. So the bigger budgets get a bigger portion of finance, and then the patients that they see, they probably got a bigger budget because they see more patients, so those patients eventually all get a share of the cost. But every single thing that we do in the trust gets allocated to patients in some way like that.
If you met with your costing team, they normally have an allocations booklet which they'll be able to show you, you know, for your service, how the costs are being allocated and, you know, to which specialty and so on. And that's what we do when we're engaging with our clinicians. That's what we're showing them, you know, we're taking these costs off the ledger and putting them over these patients, this cohort of patients, and we're asking them, is that correct? And, you know, using the job plans and so on.
Somebody's asked in the chat, what is business intelligence? That's the name that our trust has for our information department. So the data analysts and the people that collect all the data and do all of our data reporting. They run our data, the back end of all of our data, basically. All the clinical systems feed into them.
Any more questions or?
I'll just move on the presentation. There's the podium for the play cost right, and then there's a quick feedback after that. If you could please fill that in.
Neil.
Yeah.
Yeah, usually if we were doing this face to face, we'd have a few prizes, chocolate bars and that, but
they have a bouncing name instead.
Yeah. Is there any feedback on this, Michael?
Yeah, I'm just going to put that now.
Yeah, because it's the first time we've done this using Kahoot. So if you could give feedback on how you think that works, and I know it's quite hard with the engagement side, so we went down the Kahoot way to try and get people's feedback, but I am conscious that, you know, it might have made it a bit quieter as people not speaking up as much through the presentation. So yeah, if you could give your feedback, that'd be great. Does that come up on everyone's devices to give feedback now? Yeah.
No.
Yeah, so people must be getting them.
Okay. Okay. No, thanks very much for that. If there's no further questions, yeah, hope you've enjoyed it and you got something out of it. If you do have any questions on the back of this, you can either email. I think, have our emails been sent out to the delegates?
No.
No.
I can add them to the email where I send them the presentations if you're happy for them to have
Yeah.
the email.
Yeah, that'd be great. If you could add our email addresses on, or alternatively, if you contact your own costing teams at your trust, I'm sure they'd be able to explore some of it in more detail.